think there's kind of a trauma in my childhood of feeling like I didn't get to play enough. And it sort of has driven, it's a metaphor that drives me throughout my life and throughout my creativity. It's rare, but when you tragically find patients who really cannot play at all, that's really kind of a very bad prognostic sign, unfortunately. You know, that something very terrible happened, that part got shut down. Hopefully we can bring it back to life.
Okay, I'm joined here with Dr. Scott Kellogg and Amanda Garcia Torres. We're going to be talking today about chairwork and psychotherapy. And to get started, Amanda, I want to ask you, from a mental health point of view, what's the benefit of looking at ourselves as having these different parts within?
Yeah. So there's, a number of benefits of kind of carrying this belief of the multiplicity of self, right? That we're all made up of many parts or modes or energies. And I think that the one major thing that gives us is incredible spaciousness and flexibility with maybe where we are on any given day in our life, what's going on, gives us a way to understand very strong or uncomfortable emotions and kind of have a little bit more patience or even empathy for them. So instead of, say you're running late to a work meeting, something I can definitely relate to. Instead of saying, oh, I'm a screw up, I mess everything up, I'm understanding myself as parts. And I might say, oh, there's a part of me that's struggling with this, or maybe there's a part of me that's very tired. So that gives someone an opportunity to kind of understand their issue or their challenge in a different way. And with that space, we can, try different solutions, maybe just give that a little breathing room, bring down some tension. So I think it's a really beautiful way of understanding ourselves and other people that allows for less judgment, more compassion, and then, space to move around.
That makes a lot of sense. And when I did the training with you guys in New York, one of the things that you said, Amanda, that really stuck with me was you have a basic approach of finding out what the deepest part of your client really wants and then fighting relentlessly for that part. Could you maybe tell us a bit more about that and your thinking behind this? Because this is not your typical approach to therapy. This is quite radical in my view.
Oh, thanks. So when we're thinking about, when I think about myself as a clinician, and I think that chairwork beautifully fits in with this, just how I approach work in general. But I see chairwork and I see ourselves as clinicians as our sort of chief job or our mission is to advocate for what's in the patient's heart and what their goals are. So any work that I'm doing, I am constantly driven by what is my patient saying their pain is? What are they coming with and saying that they're suffering with, instead of me deciding what their issue is or deciding where they should go. And then once they shared with me their deepest desires or where they'd like to be as a person or in their life, then it's my job to be really almost annoyingly perseverant with that everything we're doing is in service of this. Everything we're doing is in service of this. So if someone, wants to improve maybe how they are as a spouse in their marriage, then my work's going to be, all right, well, then we're just going to be on. What's the part of you that maybe has some anger issues? What's the part of you that desires to connect? All right, let's bring the spouse in. Imagine that they're here. Let's talk with them. And if that person resists or says, I'm kind of over that, I'm not really sure, then I see my job as really checking that out carefully. Not saying, okay, whatever you want to do, but saying, well, you came in to this work saying, I want to save my marriage. I want to be a better spouse. Has that changed? Has your heart said no? Or is there something else going on? And some patients might find that maybe lovingly annoying sometimes, but I see that as a way that I am able to passionately care for the people I work with. That's how I advocate for them in their lives. And I think that, I get much of that that spirit and inspiration from Scott and his work and how he's approached the mission of what he's created and taken on and what we've shared with the world. So yeah, he's definitely been a big influence there.
I've seen it in action, and it's quite powerful, and you really get the sense when you're watching you that you're really fighting for the client, like you're fighting for their best interests. And I know I haven't seen it like that before, so it's really, really cool. Scott, man, before I move on to Scott here, I would just want to say, could you maybe move closer to your mic, or maybe speak a bit louder? I can hear you, but I'm just thinking about the listeners in the recording. It's a little bit quiet, but it's not too bad. All right. Scott, I wanted to ask you, I've heard you say elsewhere about 99% of psychological problems. This might be, I'm obviously paraphrasing here, but 99% of psychological problems could be attributed to either the inner critic or responses to the inner critic. Could you maybe expand on that a bit? And I want to know how you arrived at that kind of understanding.
Right. Well, that's actually a quote. I'm quoting somebody else. So I'm quoting James and Catherine Elliott, who developed a form of chairwork dialogue called anthetic dialogues, and it's kind of like an REBT, but they focus centrally on the inner critic, and kind of confronting and it's sort of battling the inner critic is the center of things. And I've come to, it's a metaphorical statistic, not an actual one, but I think there's a lot of truth to that. So we were talking about this before, but so many diagnoses, depression, anxiety are very much driven by inner critic attack. Other things are kind of coping modes. We know in addictions, worms are talked about, drug use as an escape from the inner critic, as a way to temporarily get away from it, and things like that. Most people feel terrible about themselves. There's I read this interesting thing, kind of a religious article I was reading, which is very, very striking to me. I don't know if it's true, but so, in Christianity, it says, love thy neighbor as thyself, right? And the guy writing it said, well, in the old days, everybody loved themselves. So to say that made a lot of sense, but nowadays everybody hates themselves. And there's kind of a joke, like, if you treated other people the way you treat yourself, would we need to call the police? And we've heard that before. So, we are very harsh on ourselves, and very cruel to ourselves. And so I do spend a lot of time with the inner critic. The other thing, which I think we talked about before, is there actually are two different kinds of inner critics. Or at least that's something that we've been arguing, and I see lately Wendy Bahari and Robert Brockman have written a piece echoing this. And one, what I call the internalized abuser, is a very classic kind of Freudian understanding of the superego, where we grow up with voices, people, family members, relatives, religious institutions, schools. I think especially later on for peers in middle school, can be a voice that's very harsh. They kind of live within us, and it technically, I would almost say they actually probably are not even part. They're more like internalizations of other people, but we kind of experience them part. And they're very, they're very cruel and damning. But what the Stones first came up with, and you see this in IFS as well, is this idea that the critic actually develops as a coping mode early on in life to keep the patient safe, to keep the individual safe. So, like, you better do well at school, watch what you say, all these admonitions about our behavior so that something bad doesn't happen. And schema therapy, as roots in, certainly had favored the first one for a long time. I think now we're moving to kind of a two critic model. And so one of the first things I do is actually, as a patient, to move to another chair, and I actually talk to the critic, and I wanted to basically do a differential diagnosis of the critic. you're telling somebody that they need to lose weight or they need to work harder or whatever it is. How come? Why does this matter to you? These kind of questions. Leslie Greenberg, I think, very powerfully kind of said, like, what's the core issue? Kind of, why is this important? Why do you care? Right? You're getting kind of and what you find is in these abuser critics, they really hate the patient, and you can really feel the hatred come through. But with the kind of coping mode critic, you feel the anxiety. If he doesn't work harder, it's going to be a disaster. If he speaks up, he'll make a fool of himself. These kinds of things come out, and then you kind of can work from there. They're kind of different strategies depending on the critic.
So you would disagree with Dick Schwartz's notion that there are no bad parts, like that you wrote that book in that?
Right. I kind of say they're mostly no bad parts. that's kind of my slight amendment to Dick Schwartz's work.
That's your next book title.
Yeah, mostly, yeah, right. And Jeff Young, had worked with so many. He's just a genius. Was a genius in general, but a genius with borderline personality disorder. That's extraordinary compassion for borderline patients, and these are highly, there's a lot of, not everybody, but there's a lot of abuse in that diagnostic group. So it's not surprising he hears these voices of horrendous parental figures or abusers, So if you go to that highly traumatized population, you're probably going to hear a lot more of it. My kind of another informal statistic was like, it's 80-20, 80% coping mode and 20% internalization. Rob Brockman says in Australia it's 85-15. Probably depends on the culture. But this has been a great revelation. I spent a lot of time talking to inner critics, actually, in my work. And and trauma can lead as well, can lead to inner critic or activate inner critic issues as well. So does that make sense to you? I mean, you've talked to a lot of people. Does that sort of land with you in these kind of?
It does. And my understanding of what you said is, and correct me if I'm wrong here, but you're sort of saying that there are two ways an inner critic can sort of show up for a person. One could be where the person has internalized an external abuser, like someone that has given them a hard time in the past, and that's become not part of them, but it's sort of, it's living within them. And then there's another part where the person will develop a protector part or a coping mode that sort of like keeps the person right, keeps them on their toes. It's really harsh on them to avoid getting that kind of abuse again in the future. Is that sort of what we're talking about?
Well, it may not be that they would be abused again. It may be just more like, it often develops around the age of 6, going to school is sort of keep them safe from some sort of, social disaster, or there may have been some kind of trauma that took place where this is the lesson of the trauma. Well, so one thing I didn't say was these coping mode critics, while they can be dramatically unpleasant, can actually be quite helpful to people growing up. But usually when they've come to the office, it's like they're no longer, this is the classic schema therapy coping mode argument. They're no longer helpful anymore, right? It's either too much or they're, and Freud pointed out the inner critic is not connected to reality. They're just so running on fear that they're actually interfering with the patient's functioning. And for those critics, we want them to kind of step back. We want them to actually come like an ally or a coach to the patient. It's not going to go away, but we want to change their role. And then, the person kind of can say, I can deal with this. I'm not 4 years old. We had a very funny experience in Australia. We were working with this woman, and I was talking to her critic, and she's going on about this critic, and very repressive to the woman. I said, this is a 32-year-old woman you're talking about. And the critic went, what? She's 32? What? When did that happen? It was very funny. It's very spontaneous. I think she's like 6 years old or something. It was quite a dramatic thing, which I don't think she was faking. I think she was just like, it just was very amazing to see that. And that was a beautiful example of this coping mode not being in touch with reality anymore.
That's so interesting.
Yeah. The whole place was like laughing and kind of awestruck by this unexpected emergence, of a part.
One of the things I've learned from you guys is that maybe the central role of psychotherapy is to strengthen the inner leader or the healthy adult or the ego. Um, so something that comes up for me here whenever I think about this is that when you're doing your work, how do you know when you're speaking to the inner leader? How are you sure? Because there are some people that will have a very high functioning um coping mode or protective part that's highly successful in one domain in life, but it's not the inner leader. So Amanda, have you any thoughts on that?
I would say, in my experience, one of the ways to sort out if when I'm with someone, is their inner leader present, or do they even have a fully developed or strong present inner leader, is what's their level of consistency and how they're showing up in the various areas of their life. Are they maybe just totally, dominating all their projects and so highly successful at work in their career, but for whatever reason in their home life, they are completely falling apart. Or when they go to the grocery store, they just will have a meltdown if they can't find the eggs. something very different. So things like that are very big indicators that maybe this person operates more from a coping mode in certain areas of their life, but their inner leader actually isn't the one driving the bus. Because what the inner leader gives us is the ability to be fairly consistent in how we present. So, so I tell patients when they ask me, well, what do you mean inner leader? What are you talking about? What do you mean you want me to fake it till I make it? Or am I putting something on? I say, no, actually. So what I like to tell them is, so for example, as I'm with you and I'm talking to you now, Niall, you sort of see I have a certain kind of demeanor, way of talking, way of being. My hope would be that if you ran into me in a few months, say on the street, and, maybe I just got out of a party or something, it's the weekend, that after you run into me, you wouldn't be so confused and shocked. You wouldn't have that moment of, oh my gosh, I barely recognize that person. What's that? They might say, oh, that's funny to run into her. Took me a second. But my hope would be that there is still, no matter what, even if I'm not in like my work mode, that there's a level of consistency in my demeanor, my presence, and who I am as a person, right? So sort of like a cut gemstone or diamond. So when I'm working, I'm putting one facet in the front, right? That's my work facet, my therapy facet. But it's still the same stone. So you should still be able to recognize me enough and be able to connect with me enough, even if there's another facet in front. So it's very important to have something like an inner leader. That's discernment, adaptability, all of that stuff. And it also helps the clinician to not only advocate for the patient, going back to that theme, but also kind of take a step back and also have a stance of humility. Because I'm not in charge of making decisions for the patient's life or telling them where to go or how to be. It's their inner leader. I'm not the expert here. So yeah, I think it works in a really, really neat way. But, yeah.
So a sign of a healthy internal world would be that someone shows up not equally well in all areas, but relatively well in multiple different domains of their life, rather than just being amazing at their work or amazing at one specific thing. So that's a good, and if someone is really successful in one area, but is lacking that in other areas, it's a sign that it's a coping mode that's running the show. And that's a problem. It's a big problem.
Yeah. And someone needs to have a center, right? And we see people who kind of will dramatically sort of shift how they are. It's because there's no one in the middle. There's nothing in the center giving them that consistency. Maybe they're very volatile. It's like, ooh, you don't have a driver.
But then this brings me
in the back are just taking turns and no one has map. Like, okay, that's fun.
And this brings me to another question I wanted to ask you guys, and maybe we'll go to Scott for this one. There's just, the concept in Buddhism of no self. Do you feel there's any conflict here? This idea, the ego gets a bad rap in a lot of these kind of philosophies and everything. What's your thoughts on this, Scott?
I think there's a major battle there, and may have, that's been a disturbing issue for me, of the attack on the ego from so many spiritual or spiritually influenced psychotherapies. I think the whole point of psychotherapy, and Freud actually said this, is to strengthen the ego. And maybe this is partly an Eastern Western difference, but I think many people are very confused about what the ego is, and then they're attacking something else. So, I want what I want when I want it is not the ego. That's actually the id in Freudian terms, or some sort of child self. That's maybe an angry child in schema therapy mode. That I have to get all the attention from the world is narcissism, and narcissism is another coping mode, a grandiosity coping mode in the face of a damaged ego, or underdeveloped ego, or inner leader, as I would call it. So, the inner leader, the ego, the inner leader is the heroic self, the self that chooses values. It just says, I'm going to live a life based on my values, that I can say yes, that I can say no, that I can persevere, that I can choose courage over fear. I mean, I don't know if you've ever done meditation or if you're a meditator, but the idea to go and meditate when you don't want to is basically an ego decision, So without an ego, but maybe the language is getting confused. They probably should not be using the word ego, because it's a word from psychotherapy, and this is kind of a non-psychotherapeutic approach to the world. It's a religious, spiritual approach. Maybe related to that, I do think that mindfulness, actually, I see as a capacity of the inner leader, as a way of observing the other parts or modes in action, right? Because in many patients, these other parts, maybe fear, whatever, anger, they're still stronger. They still take over the system. But the first step, and I say this a lot, is, can you observe it? Can you label it? Right. And you see this in voice dialogue. So I feel like that is kind of an ego capacity, or inner leader capacity. So that's where I think mindfulness can be helpful, but I see it as a part of the ego, or the inner leader. It's a skill that we can learn from a psychotherapeutic perspective. And yeah, go ahead.
It makes me think, there is a lot in the popular culture around this idea that the ego is the source of almost every major mental health problem, particularly like spiritual books and things, right? And then, it's just, as you're speaking there, it strikes me that maybe there's like young people that really don't have this fully formed sense of self yet, or inner leader yet, and then they read these books, and it could potentially be quite damaging if they are, reading that, and they are realizing that, or they're thinking that this thing that they should be developing is something that they should be avoiding. What do you think about that?
I would agree with you. I think that could be quite disturbing, and problematic. There's a man I like, Dr. Harry Emerson Fosdick, who's kind of a religious teacher and a psychotherapy teacher in a way. And he talks about, character, and an old-fashioned sense of character. But what is it to be a man or a woman or a person of good character? Is to have a consistency over time and over place, right? And Zimbardo said, the heroic self is to, under pressure, to not kind of abandon your value system, and these are all things about strengthening this ego, and both to say no to things and to say yes to things. And we all struggle with it. I mean, we all have problems with our egos. They're all damaged. They're all, not the way we want them to be. But yeah, I mean, it's two different worldviews, and I'm in the Western world, and I think that's important. And in psychotherapy, at least, it's important. Moving things beyond that, then that's another realm, not my expertise. But
the word that comes to mind for me here is integrity. That's maybe kind of what we're aiming for,
But that's a very good word for this. Yeah.
So we've been speaking a while now, and we haven't actually brought up the main topic of conversation, which is chairwork. So Amanda, what is chairwork? What's the aim, and why do you think it's so effective?
Yeah. So chairwork, it's traditionally been practiced and understood as an integrative experiential technique. So it comes from psychodrama and Gestalt therapy. Other integrative therapies along the way have expanded, sort of shifted that. And so we can understand it as an experiential integrative technique, or as myself and Scott practice it, as a standalone psychotherapeutic modality. And it's all about, facilitating a dialogue so that someone can give voice to their inner parts or modes, or facilitating a dialogue so someone can engage in a dialogue or enactment between themselves and someone from their past, present, or their future. So it's all about dialogues, enactments, giving voice. So instead of talking about things or about other people or about issues, we are engaging directly and talking to and from them. Instead of talking about what's in my heart, I'm actually giving my heart a voice directly. So kind of giving them the phone, letting them speak, putting them on speakerphone. So it's a very intense, energizing way of working. That, I kind of will compare it to the boot camp class. It's like, if you're going to sign up for the boot camp class, you're going to sweat. You might be sore in some new muscle groups you didn't realize you had, but something's going to happen, and something's going to happen pretty much every time. So I think it's such a fascinating, amazing way of working.
Very cool. Now, in terms of why this works, something I've heard you say in another interview was that maybe it's that we're creating, so if you're working in chairs, you're creating this space between different parts of yourself in the external world. And then like, for example, if you are working with an inner critic and you can see your inner critic 5 meters away or 5 feet away, then you're creating this space in the external world, but then that helps to create this differentiation and space within the internal world too. And then that is, for me, that would be a very helpful thing, because then these things aren't running you anymore. They are, there's a dialogue happening. What do you think?
Yeah, I think there's an incredible advantage to spaciousness, which, can be accomplished externally. Internally, because I practice chair work, I prefer externalization of that. I think there's something not just to imagining space, but literally moving, creating a physical shift of some sort, I think is actually really key to going very, very deeply. So I can sense you are over there, I am over here. Let's talk. Let's do something about that. So that can make things a little less intimidating. I think it's also a much more powerful way to rebalance energies. Who or what is more powerful? So we have the advantage of, I can speak more loudly to you. I can stand up. I can sit up straighter. And that creates more of a sense of equality, I think, between these energies, if that's what we're going for, which much of the time we are. So I think there's a huge advantage to getting literal space from things, from other people, forces, or bringing them very close. So having that option, right? Can push something away that maybe has hurt me. But if I'm engaging with my inner child, I want them very close to me. We can have more of an intimate interaction. I think it gives space to stand up for oneself, rebalance the energy, and then to more literally nurture a partner and energy too. I think space is so important.
Very cool. And how essential are chairs in chair work?
Chair work actually isn't about chairs, so we should probably figure out a new name one day. So that's our tagline. Yeah, so chair work is not about chairs. It's actually about shifts. The most important thing is making, shift work, right? Working in a shift. So chairs are the sort of, chair work is the traditional term. So we're following in a tradition, in a long tradition. And chairs are perhaps maybe the most useful tool to facilitate the work, though really it's just about the shift. So you can do chair work without chairs. You can use Post-it notes as placeholders on the ground. You can, hold an object in one hand or the other. And, because it's not about literally the chairs, I can do chair work with someone over the phone, even if I can't see them, as long as they are making the shift as I instruct. So that's just moving about and moving things around.
Just a quick break here to tell you about an exciting new membership we're developing, and then we'll get right back to the show. This gets you access to our mastered library of over 5 years of psychology conferences, including over 230 talks and interviews with the world's leading psychologists, professors, and authors, unlimited CPD certification, transcripts, quizzes, premium passes for our annual conference, online courses with Richard Schwartz and Deb Dana, and more. The cost is £97 for 1 year, which breaks down at around 27p per day. The best bit is you can try it out for 30 days completely risk-free, as all orders come with a 100% money-back guarantee. If you're interested, please go to twmembers.com for more information. Very cool. So we've come up with a new term for chair work, shift work.
Mm-hmm.
That'd be the title of your first book, or I don't know if you've already written one or not, but yeah.
Chair work or shift work?
So in observing both of you guys do chair work or shift work, I would say, Amanda, this is a compliment, by the way, but I would say you're like a warrior. You are like, you really go for it. And then Scott, you've got this sort of playful kind of curiosity, very, you're just, you get the sense that you're playing, but in a serious way too. Where does this playful orientation come from for you?
I think on a personal level, I think there's kind of a trauma in my childhood of feeling like I didn't get to play enough. And it sort of has driven, it's a metaphor that drives me throughout my life and throughout my creativity. So I played sports, I played music. In some ways I played with chair work. And I think, people have written about play as being a very kind of deep and profound thing. Winnicott talks about play as the essence of mental health, which I think is very beautiful. And he also, and I believe, it's rare, but when you tragically find patients who really cannot play at all, that's really kind of a very bad prognostic sign, unfortunately. That something very terrible happened, that part got shut down. Hopefully we can bring it back to life. But but I like Winnicott's idea of play as a kind of a healthy way to be. And for me, it's very creative. And it's also, as you saw, we deal with some very profound and difficult stories and very painful things. And use, that can be a little way to kind of connect with the patient and be present with them. But
for sure. Now, am I right in saying there are 4 principles to this approach? Can you maybe tell us what those 4 principles are? Just like the overview. You don't need to go into too much depth here, but what are the 4 principles that this is based on? I should probably direct that. Amanda, do you want to give us that? And then
Scott's up.
No, I'll tell you what, Amanda, you give us the 4 principles, and then Scott, if you give us the 4 dialogues. How about that?
Swap that.
Okay, we'll swap it. So
I promise I know them. I promise. But yeah.
Okay, Scott principles, Amanda dialogues.
Yeah, so suddenly she went back to some sort of final exam in junior high school that she hadn't studied for enough, and there was like, you saw the trauma.
I'm the leader. I'm the inner leader. I can say yes and I can say no. And I said no.
So these are 4 kind of overlapping ideas, but the 4 principles are, the first is multiplicity of self, and that we have different parts. And, I think I've said this many times, but John Rowan, who was the British humanistic psychologist, just argued that parts work is the future of psychotherapy. And I think we're seeing more and more therapies that really are using parts, IFS being obviously an amazing one, schema mode therapy being another one. Hopefully our work is one. Compassion focused therapy has some work with parts. You're seeing this. I mean, even Freud originally is parts, id, ego, superego, defense is a part model. So parts have sort of moved through that. I think you see it in David Burns's work in CBT. He doesn't quite say it, but it's implied a lot in his language. But parts to me is fantastic. And, in other spaces, I sometimes say, what, if there's one thing to define a psychological approach to the human being is understand that they have parts. I would say that's so essential to that. So not only is it useful to understand that people have parts, but also, as we've been talking about, it's very helpful for them to give voice to these parts. That's sort of therapeutic to give voice to these parts. That's the second principle. The third principle is what Amanda said before, is the opportunity to enact or reenact scenes for the past, the present, or the future. And that really connects us to the psychodramatic origins of Chairwork. Chairwork begins in psychodrama, is then more developed in Gestalt therapy, and then goes to the world. And that the fourth one, which we've talked about before, is that the ultimate goal of Chairwork, and I would really argue the ultimate goal of all the psychotherapy, is the strengthening of the ego, or the inner leader, or the healthy adult mode. And this is our true north. And sort of when you're a therapist, where is the ego, where is the inner leader? Keep going back to that, keep trying to find that part, and because the stronger the inner leader, the more everything else lines up. So in a way, and this comes from our schema therapy origin, we're almost kind of a transdiagnostic approach, because whatever the problem is, it's always about parts, and it's always about the inner leader in different forms. It's always this kind of core dance, or pretty much for something about trauma stories, but pretty much that's it. So those are the four principles that we kind of anchor ourselves in. And then we have the four dialogues that Amanda is going to tell us about.
But before we go there, just a follow up. So do either of you have experience working with clients that have quite extreme forms of dissociation? And have you found Chairwork to be in any way helpful in those contexts?
I wouldn't say I haven't had a lot of experience for it, but in schema therapy language, dissociation is a coping mode, right? So it's dissociation itself is one form of coping. So you can, you kind of talk to the patient, go to the chair, so you're the dissociated part, and often there's a negotiation with that part saying, I'd like to go into this child part, really, that's in a lot of pain. The inner leader wants to do the therapy, but you are coming in to protect, and how would you feel if I worked with this child? And you can stay nearby if it gets too intense, but were you willing to step back a little bit? That's one thing. And then we also have the patient go to the inner leader chair and talk to the dissociative part and say, it's okay. I'm willing to do this work. I feel strong enough, but stay close by. So it's a negotiation, with dissociation as a coping mode. And that's a basic model. What I more commonly see is kind of a shutdown. I wouldn't say a full scale dissociation. I can have a shutdown. There's no emotion. The person's like dead, right? And that means they've dissociated in a smaller way. So I don't know. Is that helpful? That answer?
Yeah, totally. Okay, Amanda, 4 dialogues. You're up.
I'm ready. I'm ready. So the first, I don't know, maybe I'll just say a sentence description of each. Keep it brief. But the first is telling the story. So that's where we have someone move to a storytelling chair and they express traumatic memory, difficult memory, something that happened to them. Or they can even work with a positive event that they experienced, something they want to integrate. So that's telling the story. The second would be giving voice. That's where, again, we set up chairs, we have someone move after they establish their inner leader, and they embody or channel a part of them. So that's essentially what Scott was just describing with a shutdown, with a numbing part. So it's a way of engaging with them, getting to know them. And then the third, we can understand as relationships and encounters. So that's where, again, we're setting up the chair so that someone can have an imaginary dialogue or enactment with another person or force. So that can be someone from their past. They can speak to maybe a parent that has passed away. They can engage with them in that way. So we have, let's see, and then internal dialogues. So that would be where we're bringing in, for example, 2 parts of a person, and they're engaging with each other. So the parts of the modes are now having a back and forth dialogue. So you can understand that, a common thing would be decision making. And so one side, someone will express, I want to have this job. I'm going to go for it. I'm going to accept the offer. And then they move to the other side. They address the other part. I hear what you're saying, and I want to stay where I am. So it's a way of engaging with energies that are inside, bringing them out. Those are the four. So that's, what did I start with? Telling the story, relationships and encounters, giving voice, and internal dialogues.
Yeah. Okay, cool. And one of the things that I found really interesting from the certification with you guys was storytelling and how beneficial this can be as a therapeutic tool. So can you maybe tell us a bit about how you might use this in therapy and the importance of the third person? Why you've opted for that over saying in a first person or a second person perspective?
So I think both myself and Scott are in agreement here with maybe why we've sort of gravitated toward third person storytelling over first and second, is that we both really appreciate the spaciousness. So not only in telling a story and, I'm Amanda, and when I was 5, something happened to me, versus, once upon a time, there was a little girl named Amanda, and when she was 5, something frightening happened to her. So that's using the third person voice. When we do that, again, it gives us space. So I guess you could also call it space work. Might create further confusion. But so that gives us a way of getting space from the story, from the narrative, and more freedom to work with it. Right? So new perspectives can come in. It's much harder to judge a protagonist in a story, judging someone else's story. And it's also much harder to be unfair about how we see the story. So it very naturally kind of gets that door cracked open for some more empathy and compassion to come in for the protagonist of the story. That space might also help someone feel more comfortable to engage with the content, especially if we're working with a trauma. That content can be very distressing or disturbing. So it can be a bit more comfortable to tell the story about someone else versus speaking in the I. We do that 3 times. We tell the story 3 times. We reset in between. And you can understand this also as a form of exposure therapy. So we all get used to the content. Clinician gets to learn about it. But yeah, the third person kind of is an amazing way to sort of shift doing that work that I found just profoundly effective. And yeah, I rarely do the other forms now, although they do work. But I love this idea of getting the space, particularly with trauma, so we can have the hyper arousal, but also the space. I think it's a beautiful balance.
I would add to that, that having worked with addiction for a long time, you also see situations where people are traumatized, but they feel they have some role in the trauma itself. I actually have a patient who was, patients who were traumatized, involved when they're doing criminal activities, So there we have shame and we have guilt and we have responsibility, and this makes it very complicated. And third person storytelling gives them a way to be more distant in terms of shame and right, because it's one is the fear and the disturbing aspect. The other is responsibility and guilt. This because they can get more distance, and that is really incredibly helpful as well. And talk about that person as somebody else.
That makes loads of sense. And at the workshop, I seen this in action where there was a woman who went through, I'm not going to say the details, obviously, but went through an experience and told us the story in the third person 3 times. And you just noticed each time she told the story, it was getting easier inside. And you could see a massive relief in her by the time she had told the third story. It was totally changed for her internally, So if you were just wanting to give a quick guideline to a mental health professional that wanted to try that, would it be you get the person to tell the story 3 times in the third person? Is there anything else you'd add on top of that to supplement what I've said there?
Well, we always have someone move to a different place than where they were sitting before, where they usually sit for the therapy. So it's very important that they move. So that's a way of providing containment and also signaling to the self that we're going now into a different emotional, mental, energetic space. And easier to have containment afterwards when they move out of it. So again, the physical shifts are pretty great. So we have them move and then prompt them. So tell the story in third person. So once upon a time, there was a girl, this is what happened to her. Encourage them as they need to. When they get done the first time, then they will do a reset. So that's an opportunity for them to ground themselves. So this is where, if we're really concerned about flooding, overwhelm, person has an opportunity to reconnect. Remember, they're in the here and now. They can stand up, move around, breathe, take a sip of water, and then they sit back down and tell the story again. Finish, move around, whatever they want to do, take a little jog around the room, exhale, sit back down, and then they tell the story again. Then we have some space to debrief, make some space for the patient to sort of share their observation about the story. I'm telling a story, I'm noticing that I feel some understanding for that little girl. She was doing her best, and it breaks my heart that she blames herself. I don't think she should, whatever it is. Again, allowing that door to very naturally open for that to come in. Wrap that up. And then the patient will move away from that storytelling chair, come back in. The therapist will come back because they both moved. And then we debrief together. That's essentially what that is. So it's fairly simple and straightforward. It can be very deep.
One thing that Amanda does really well, usually on the third time around, what we call a deepening technique, which she will kind of work with the patient to repeat things. She will say, and then she went into that room. Say, then she went into that room. And this kind of heightens the drama a bit more. It becomes a little bit more, you should describe what you do, but you do that so beautifully and so powerfully. I think you saw that, now, I'll just talk about it a little bit, Amanda, if you would want to.
Yeah, so as the clinician is listening to the story, sort of, and I'm always keeping notes kind of in the back of my mind of what I think are maybe the hot spots of the story, particularly notable moments that maybe wouldn't be what the patient would say was the most difficult part, but sort of getting from them, just based on observation and some intuition, what I think is very meaningful about that story. Is there something about that moment they walk back into the room? Or was it something about that detail of, and usually it is, this terrible thing was happening and she was a little girl, and she didn't have control. But so really pulling for what are some of the things that really make something traumatic, right? So that's, something was developmentally inappropriate, right? Or something was particularly really frightening. Trauma is scary, that's why it's traumatic. Or there's loss of control. It's always an element of trauma. So really highlighting that, pushing that. It's not about torturing people. I tell my patients that all the time. It's not that I want you to suffer. It's that you are haunted by this, carrying this within you. But my job is to provide the space so you can confront it in a very powerful, moving way. And then trust that will allow the integration to come in. You will not integrate these parts of the story. You will come back into yourself. So that is why we use the deepening techniques. We believe that we're not trying to dampen down the intensity. We're actually doing the opposite. We want to encourage it to heighten within the specific way of containing and re-experiencing. And then the integration very naturally occurs.
One other thing about this, which maybe you're going to get to now, is we certainly we talk to patients, who come in with a trauma story, and they say, have you been in therapy before? Yes. Have you ever talked about it? And they say, well, I told the story once and then we never discussed it again in therapy, right? And this is, believe it or not, not an uncommon experience. And why is that? So, trauma stories are disturbing for the patient. Trauma stories are very disturbing for the therapists, right? And, we kind of, our whole body kind of, we would close up, we want to hold ourselves. We want to be defended against these stories. These are not easy things to do that. But when you take this approach, you're creating an approach where you know you're going to do, it gives the therapist permission to do it repeatedly. So what happens for the therapist, I think often, is that we begin to habituate to the story. Right? You're hearing a story 4 times in a row, 5 times in a row sometimes. We can begin to relax. Our body, shoulders drop a little bit. Now we get more comfortable. We've also shared it more with the patient. There's a relational component to this as well. So now we have the freedom to actually work with the story, work with very detailed, some of these, even very intimate sexual details, because we feel more comfortable. So this is a huge gift for the therapist. I think most people don't think of it that way, but that we can get much more relaxed, much more freedom to work with that. So by teaching people, you're going to do this 3 or 4 or 5 times in a row with your patients, it sets up, I think, kind of a structure of parameters that will give us permission to get habituated. Otherwise, we're kind of, most people are afraid. They hear the story once, they're afraid they're going to traumatize the patient or make them upset. But, it's just, obviously some people do exposure therapy where that's the therapy, but a lot of people say, yeah, I told it once, I never told it again. And so anyway.
So Chairwork has a wide range of potential uses. You can use it for trauma, you can use it for, I think, things like OCD. But your background's in addiction treatment, Scott, and we just done this summit on addiction, and I'm kind of devastated that I didn't know that your background was in addiction before I found out the lineup for that. But for how can Chairwork help treat addiction, do you think? And if you've an example of someone that was struggling with an addiction where Chairwork might have been helpful in some way, I wanted to ask that.
I'm thinking, on the one hand, why did he invite me to his summit? The other hand, going, well, he didn't know, and he invited my friend Andrew Tatarsky, so that's good enough. Play my 2 sides. So I think, so addiction treatment itself is a specific kind of way of working with patients. And, Andrew Tatarsky, and so he and I are, have similar perspectives on addiction treatment. So in some ways, to use Chairwork with addiction treatment, you have to understand addiction itself. You have to kind of understand how to treat people with addiction. It's not just chairs exactly. It's the one diagnosis where you have to understand the diagnosis more than just do these things. But a couple of things, the first and foremost, most basic one is there's a part that wants to use the drugs, and there's a part that wants to change. Continuation, change, the core thing, right? And inner leader. So this dialogue, speak for the part that wants to keep doing what they're doing, speak from the part that wants something different, however that's described. And in addiction psychotherapy or harm reduction psychotherapy, we go back to that, or at least I go back to that relentlessly. I'll do it even every session sometimes. I want to keep doing this. This isn't working for me. I want to make a change, because that's where the fire is, right? Motivational interviewing is another form of it, but you want to keep that tension, right? So I talk about the horizontal and the vertical. So that's the fire for the horizontal, right? So then if I were going to make, all right, so the sum of happiness, what is something that you might do, right? So maybe I will, I often start, I'd say, how many drinks are you having a week? I'm having 35 drinks a week, right? So they go, okay. So this week we'll start with, let's do, if you're willing, let's set a boundary at 35 drinks a week. You can drink up to 35 drinks a week, but you cannot drink 36. And if you drink 36, we know that something happened, right? So Alan Marlatt, in his book, quoted a Zen saying, to keep the sheep happy, give it a big pasture, right? A beautiful, beautiful saying, right? So we have a very big pasture. So they say, okay, I will, they agree to it because they want to make a change. And so if they do it, they're successful. And if they drank 36, so we can take that story apart. Like, what happened here? What was the moment? Let's walk this through. Let's go through the experience. Tell the story of what happened, right? Another way to do that. Another part got up. Hey, if you could redo this, what would you say? How would you manage it? So everything's an exploration, right? So that's sort of one way to do it. The other thing is that, many people are inner critic or trauma. It's all over the place. And many people are like, I'm really upset. I have this voice in my head telling me how bad I am, or I remember terrible abuse, and maybe that needs to get addressed first. We dance between the horizontal and the vertical. That's the beautiful dance. Gradual change. And we also can have them talk to the drugs, which is very interesting, and have them actually be the drug, which is drugs often don't like the people who are using them. And I often say, he spent $30,000 on you. Don't you love him? And they'll go, or love her? And, nope, I do not. I think he's a loser. What? It's very funny that and people can be, quite astonished to hear their drugs talking back to them. It'd be really, they've dedicated their life to this relationship with someone who doesn't really care for them. So, let me just give you a brief overview, but there's lots of things we can do, but it's all the sort of, intention, what do you want to do? Did it work? Did it not work? What happened? Let's take it apart. But again, I want to keep doing this. I want to change. And this could be for food. This could be for anything, right? We were all wrestling with these issues.
That's yeah,
is that good enough as an overview?
That's so interesting. Like this idea of like the person embodying the drug and taking the drug's perspective, and then the drug actually having hate for the person. I can see that being very helpful in addiction treatment. So something else that is really interesting about your approach that goes against many of the conventional norms of most therapies is that it's very directive. Like you will put words in the client's mouth. You will suggest things for them to say, and then they will say them. How does this? I'm trying to ask here. Can you maybe, Amanda, tell us like how this works, and why do you think it works as well? Like to suggest phrases for them to say, and what are your thoughts on that?
Yeah. So in our work, we call that sort of feeding the line. So make a suggestion. So say someone's talking to the drug, and say, I want you to try to say this. Say, I love you, and I'm frightened that you're going to hurt me. Try to say this. So the point of feeding the line isn't to sort of enact any sort of agenda that we might have. And of course, therapists are people too. So we might have our own desires and wishes for the patient. But in chair work, it's not about us. It's about them. We sort of facilitate, but no advice. No, it's all about their stuff, their parts, their inner leader. So the purpose of feeding the line is to help them access what's already there, what is already happening. So when I feed a line to someone, it's not because I think it would be funny for them to say, or because I want them to secretly change their mind about something. It's because I suspect that is what they may actually feel. And maybe they have been frightened to express that, hesitant to express that, or felt that they have not had the permission or the space to go there. So again, I see it as a way of advocating for what is in the patient's heart. I'm telling you to say this very difficult thing because I am fighting for you. And if I wait for, and Scott says this all the time, if we wait for patients to get there, many of them will take years to get there. Which is when I'm with them, I can sense, I feel like you're talking to your spouse, and my spidey sense, and I say, this feeling that maybe there's a part of you that's really in grief here at this lost connection. But if I wait for that person to get there, they might stay in anger, right? People like staying in anger because it's more protective. People want to avoid grief and things like sadness or resentment even. If I feed a line so someone can explore that, they can try it. If it doesn't work, that's fine. That means we got information. Okay, we're barking up the wrong tree. That's helpful. We learned something. But if it's right, now things can really, really speed up and deepen. So that is how I advocate for people. That's how we advocate for the work. Keep it on track. So it's not that. So I will tell people it's not my idea that I think this is what your inner critic thinks, about you, because I want you to hear bad things, because I'm sensing this is the battle that's actually going on. It's not what I feel about you, but I think this is what actually is happening. So this is how I will fight for you.
It strikes me that this approach requires the therapist to be a highly developed and integrated person themselves in order to give that kind of guidance. You know, I wouldn't want to be receiving these lines from someone that I didn't trust. Do you know what I mean? Like, it would need to be someone that I really trusted. So that strikes me as very important.
I would say it actually helps to develop trust and rapport. Because when someone feels that, oh my gosh, you had me say that thing, and I just, oh no, weeping, or I feel so moved by that. Wow, you really get me. So it's a way for someone to feel really seen and understood and felt for, that I think is incredibly unique and powerful. And then it gives them the option too to opt out. If I say it once, it doesn't fit, cool, no harm done, it's fine, we'll move on. But I think it's actually an incredible way to deepen the therapeutic relationship and alliance. I'm showing you through the feeding the lines that I am so in touch with what your desire is, or what's in your heart, or what your pain is, that I'm supporting you and opening that door.
Yeah, I've experienced it firsthand. It was Scott, and I'm not going to repeat it, but I still remember the exact line that Scott repeated back to me. So it's powerful. So just a couple now to wrap up, guys. What are the major things to avoid in chair work? Like, is there anything that people might do that they definitely should not do? We go to Scott for this one, maybe.
I think nothing. So, I think it's coming to mind overwhelmingly. I guess, I in general, small steps. I mean, I would say that's kind of the metaphor, right? Of start gently, do a little bit, you slowly swim out to deeper water, right? And most people just do that organically. Most therapists are pretty terrified of this technique, to be honest. When they're starting, they're not like running out to, do incredible things. But as you get more confidence, you swim more deeply. I mean, Amanda and I are just, we've done 10,000 steps. We're on our journey. That's why we can do these things. But there's a series of small actions that we did, and a little bit further. In general, there's a bias in the field. Most therapists are afraid of the patients getting too emotional, right? There's, and as the wise people have taught us, patients want to do work. They can do a lot of work. They can, they can deal with a lot of emotion, and you don't get better with anxiety if you don't experience these emotions. But you do have to, you have to pay attention, and you don't want to go too far, and just check in with them. If it's like, and storytelling, sometimes like I can only tell the story once. That's fine. That's what we can do today. And Amanda talks about they can tell one sentence. That's all they can say. That's fine. So you got to be in touch with your patients, and I would say, it's do the chair work yourself, and if you're in therapy, even if your therapist doesn't do chair work, just do chair work and have the therapist witness, because the witness amplifies things. And do chair work by yourself. I do chair work by myself all the time. And that, is a self-practice. And we have paper out on chair work as a self-practice. It's very helpful. It gets you more comfortable with it. And, I would say, reading our writings, reading books, we're basically storytellers. And, getting that in your system will be helpful. Yes, I guess the main thing is, watch their anxiety. Watch your own anxiety. If you don't feel comfortable, maybe don't do that thing today. If it doesn't feel, you don't feel you're there yet. But in general, if a patient can do psychotherapy, they can do chair work. It doesn't really matter what the diagnosis is. It doesn't matter who the patient is. But you won't need to adjust for speed or intensity or, content. But it's really in a profoundly universal way of working. And gotten very few bad reports from people. Somebody's kind of pushed too hard on a patient, kind of they got pushed back. The patient was very upset with him, but that was very rare. So
amazing. Okay. Well, guys, it's been an absolute pleasure to reconnect and have this conversation. Where can people, if someone wants to learn more, dive deeper, how can they find more about your upcoming trainings? And maybe you want to tell us about your book as well, Scott?
Which I think I'll let Amanda do she's like our expert here on how to reach us. And I'll tell you about the book after that.
So people can find more details about our work, various articles, our training schedule for upcoming events on chairworkpsychotherapy.com. So that's our website, chairworkpsychotherapy.com. You can also connect with us, in other various spaces online, Instagram at Transformational Chairwork, Facebook at Transformational Chairwork, LinkedIn. We're on LinkedIn under our sort of more official title, Chairwork Psychotherapy Initiative. My social media intern, who is myself, has yet to sort out how to change the handle on Instagram and Facebook. So we still have the old social media handle, but intern's doing her best. But yes, chairworkpsychotherapy.com.
Cool. Okay. And the book, Scott?
So the book is Transformational Chairwork Using Psychotherapeutic Dialogues in Clinical Practice. And basically, so it came out 9 years ago. And this book represents kind of the, a first major phase of my work. And it's really a book of stories. And I think there's a part of me that goes, it's just like, this is really cool. And I want to share cool things with people. So mostly it's stories of other people and of how they use chair work. And I just like the best stories I could find. And I put them all together in a book. And then I created scripts. So people can really have scripts. They can really like play them out. They can act them out by themselves or with somebody else for all these different diagnoses. And, and I tried to make it somewhat realistic. The patient goes, I don't get what you're talking about. I put little things like that in there. So I had a little playwriting experience. And people report they find the book to be helpful. And, I put all the love I had into that book. And I think the stories are great. And so I think it's a great book to start with, because it's really broad overview. And I've had interesting kind of dialogue with the schema therapy people. And what, and Remco, his name was Vander Wijngaard, just published a book on chair work for schema therapists, which is a fantastic book. And the dialogue we were having was, they were saying to me, we want you to create chair work for schema therapists. How to use chair work in schema therapy, in the structure of the therapy. And I was just saying, I want to teach people how to use chair work more broadly and then apply it to their specific therapies. So like, let me teach you how to play the violin, then you can play Bach, versus let's learn how to play Bach, right? So that was kind of a dialogue we had. So this is kind of like a broad way of using chair work, which you can then apply to any of your therapy that you're doing. You can integrate it. So anyway, I love the book. I think it's great. And
fantastic. So chair work is sort of like the umbrella, and all of the different approaches can fit underneath that umbrella because it's big enough and it's trans-theoretical.
Mm-hmm. Yeah, it's trans-theoretical. It's a technique, or you can just only do chair work, which is what I do. My entire clinical practice is chair work psychotherapy, and the creation of the 4 dialogues and the guiding principles gives the framework for this to be a fully fleshed out, effective standalone modality. So I think that's really cool.
Yeah, I've said that the chair work itself is too powerful for any one therapy to control it. It's just like this incredibly dynamic force, that everybody tries it, but nobody can control it. So it's amazing. It's very unique, actually, in psychotherapy.
It is definitely powerful and forceful. When we did that 3-day workshop, you were saying, be careful when you leave here because you're in an altered state, and it really was like that. It really does have an effect on you, but we do need to change the name to shift work if it's going to develop beyond this.
Space work. Get some
space work,
yeah.
That'll
Partner
work.
up with the space agencies, space exploration. I don't know.
Sounds like a plan. Right. Well, guys, it's been an absolute pleasure. I want to wish you all the best with your efforts going forward. And we'll talk soon.
Thanks for having us.
Thank you for listening, and I hope you enjoyed the show. If you'd like to hear the full version, you can do so with the Weekend University Premium membership. This gets you access to our mastered library of over 5 years of psychology conferences, including over 230 talks and interviews with the world's leading psychologists, professors, and authors, unlimited CPD certification, transcripts, quizzes, premium passes for our annual conference, online courses with Richard Schwartz and Deb Dana, and more. The cost is £97 for 1 year, which breaks down at around 27p per day. The best bit is you can try it out for 30 days completely risk-free, as all orders come with a 100% money-back guarantee. If you're interested, please go to twmembers.com for more information.